Good afternoon, everybody. Welcome to the Rare Info Series conducted by ORDI, Organization for Rare Diseases, India. Today's topic is Advances in Pediatric Rare and Metabolic Genetic Disorders. Pediatric rare and metabolic genetic disorders are inherited, often life-threatening conditions caused by genetic mutations that disrupt normal body chemistry. These are the inborn errors of metabolism. Some examples are phenylketonuria, maple syrup urine disease, Tay-Sachs disease, etc., etc. These conditions often require early detection via newborn screening, with treatment involving specialized diets, enzyme replacement, or stem cell transplants. Key types of inherited metabolic disorders are amino acidopathies, organic acidemias, fatty acid oxidation defects, lysosomal storage disorders, mitochondrial disorders, and many more. The common symptomatology and red flags include unusual odors in the sweat, urine, or breath, neurological issues like seizures, lethargy, developmental delay, feeding difficulties and failure to thrive, liver dysfunction leading to jaundice and hepatomegaly. Newborn screening is very important to identify many conditions early to prevent long term damage. Genetic testing, that is, whole exome sequencing, gives a specific diagnosis in some patients. Management includes, many disorders are incurable, but early detection and management, including diet modification, medication, enzyme replacement therapy, substrate reduction therapy, or organ transplant, can prevent severe progression. There have been many advances in pediatric rare and metabolic genetic disorders in the past decade, with breakthroughs in genomics, newborn screening, precision medicine, and gene therapy. This field is moving from reactive care to predictive, preventive, and potentially curative medicine. To throw light on this important topic, today we have Dr. Gayatri Dhanger, professor at the Department of Medical Genetics, SMS Medical College, Jaipur. Her field of interest is neurometabolic and developmental childhood disorders. She has ICMR certification of genetic diagnosis and counseling to her credit. She has been a speaker at many important genetic conferences. Welcome to you, Dr. Gayatri Dhanger. Over to you.
Thank you, Aparna ma'am. I also thank ORDI Form for giving me opportunity to speak on this platform. To begin my talk, I will first tell about what we mean by rare disease. Next slide. Basically, there is no clear-cut definition for rare disease. According to WHO, this definition differs from region to region. For example, in European Union, if a disease affects less than 1 in 2000, it is classified under the category of rare disease. In US, less than 1 in 2 lakh. And in India, we do not have any strict definitions. And these rare diseases are important because these are 80% genetic and majority of them are present in childhood. They are significant cause of mortality and morbidity. And by diagnosing early, we can prevent morbidity. But the main key challenges which we encounter include delayed diagnosis, limited awareness, and historically, earlier we have very few treatment options. Now they are evolving. In diagnostic modalities, it is mainly characterized into 3 categories: cytogenetics, molecular, and biochemical. In cytogenetics, it includes karyotype, FISH, QF-PCR, and microarray. In molecular, it includes PCR, Sanger sequencing, NGS, in which clinical exome sequencing, whole exome, and whole genome, and new modality like long read sequence. In recent diagnostic investigations, which are evolving include microarray, NGS, that is next generation sequencing, function validation, enzyme assay, metabolomics, RNA studies, and expanded newborn screening. First, I will tell you about the basic investigations which we do in cases of a genetic disorder. That is, first is chromosomal microarray. In chromosomal microarray, basically we detect copy number variations, and it is particularly helpful in disorders like development delays, intellectual disabilities, and congenital anomalies. And it has few advantages, like it has high resolution, it provides comprehensive genomic coverage by assessing the entire genome, it detects submicroscopic variant, and it has faster turnaround time. We can detect copy number variation, and we can analyze gene content. But there are few limitations of chromosomal microarray, like it cannot detect balanced rearrangement. So best for detecting balanced rearrangement is karyotype, and some copy number variation may be of uncertain significance. Then Sanger sequencing. In Sanger sequencing, basically DNA is sequenced based on incorporation of chain terminating dideoxynucleotide by DNA. Sanger sequencing is done by capillary electrophoresis, and it is used to detect monogenic variant and SNP detections. An advantage of Sanger sequencing is that it sequence variable regions, and for confirming the reports of NGS, next generation sequencing, we require Sanger.
Ma'am, are you on mute or we can't hear you?
It can identify disease causing genetic variant. I am audible, ma'am?
Yes, you are
Hello?
audible now. You are audible now.
Yes. Then MLP, the full form of MLP is multiplex ligation dependent probe amplification. In this technique, basically, we are amplifying molecular genetic. It is a technique which is based on amplification. And in this technique, there is basically there is a detection of deletion and duplication for the defect which can cause pathogenic mutation. Basically, MLP is effective in detecting disease like Duchenne muscular dystrophy, SMA, congenital adrenal hypoplasia, and hemophilia. Advantage of this technique is that it is rapid, give result fast, and it is efficient and accurate, and it can allow separation of small size fragment. Even a single nucleotide polymorphism can be encountered with the help of MLP. But there are many limitations of this technique. It is extremely sensitive technique. It requires expert hand. If there is impurities in the present assay, so there will be failure in reaction, which will increase the cost of assay. Then next generation sequencing. In next generation sequencing, we have clinical exome, whole genome. In clinical exome, around 5,000 to 8,000 genes are sequenced out of 20,000 genes. It is a very rapid and cost-effective technique. Compared to whole exome sequence, less data is generated, and there is less variant calling and filtering. Results are quicker, and it saves time and cost. In whole exome sequencing, basically we are sequencing the protein coding region of the genome. As we all know that whole exome represent around 2% of the genome, and 85% of the known disease causing variants are present in exome. And in exome sequencing, we can identify the variant of monogenic disorder. Also, we can identify variant of Mendelian disorders. So why whole exome sequencing? Because we know that candidate gene approach is not good to explain the complexity of the disease and disorders. Next generation technique allow us to identify the variant in whole. Basically, we are seeing variant in 3 billion base pair, or we can also search variant only at the targeted spot. As compared to whole genome sequencing, which provide high coverage, But in whole exome sequencing, basically depth is more as compared to whole exome sequencing, and it takes less time as compared to whole genome sequencing, less time and less cost. The data produced in whole exome sequencing is around 3 to 8 GB, which is easy to handle and store, and whole genome sequencing require around 90 GB data. Now, what are the benefits of whole exome sequencing? Basically, whole exome sequencing provides comprehensive genetic analysis of an individual genetic makeup. It provides us disease diagnosis, so it can reveal underlying genetic mutations. It also helps in personalized medicines based on individual genetic profile. It helps us to predict disease, so we can prevent it, and also we can early intervene. Now, application of whole exome sequencing, it is applied in case of field of medical genetics, research and forensic science. In medical genetics, is help to diagnose rare genetic disorders, in pharmacogenomics, in cancer predisposition testing. In research, we can conduct population genetic studies, understand the genetic basis of the diseases. In forensic science, it helps to identify individual from whom the biological sample is taken in case of criminal cases. Now, what are the sources for this samples for whole exome or whole genome sequences? We can take buccal scrap. It is non-invasive, but quality and quantity are highly variable. We can take peripheral blood. It is the best general source of for sample. Then we can take maternal blood, amniotic fluid, chorionic villus sample. We can take single cell from blastocyst for pre-implantation testing. We can take sample from skin and muscle biopsy in cases where we are suspecting defect in mitochondrial DNA, or in cases where blood picture is not clear. We can take sample from tumor biopsy or liquid biopsy in cases of cancer management. We can take also sample from Guthrie card, for example, in we are doing this newborn screening, and pathological specimens which are fixed in formalin fixed paraffin embedded. But one limitation of pathological samples which are fixed in FFP is that some DNA is damaged in this processing. This slide is demonstrating basically overview of various NGS techniques. Like first we prepare library, then based on the read length, whether it is long read or short read, it is further divided into, we do PCR, and there are various platforms available for this. Like for example, if this long read and without PCR, then PEG bio platform is available. Nanopore is also based or also long read and without PCR. There are other platforms also which read short read, like Solid, Illumina, DNA Nanoball, Helico single molecule sequencing. Now, how we prepare sample? Firstly, we collect the sample from the blood, saliva or tissue. Then we extract the DNA from the collected sample. Then we do exome enrichment. Then after exome enrichment, we process for sequencing of the captured exome DNA. Then we do data analysis and alignment. This slide is showing the steps of NGS, and there are some panels, like we can do test for single gene, targeted gene, whole exome sequencing, and whole genome sequencing. Basically, in single gene disorders, we go for single gene defect, like in sickle cell disease. In targeted gene panels, we test around 50 to 500 genes, and these genes, for example, in case of epilepsy and autism. In whole exome sequencing, we are checking for the exome portion, which is constituting about 2% of the genome and 85% of the disease-causing variant. Then whole genome sequence, we are basically assessing the whole genome. As we move from lower to higher, as we are covering more and more genes, so what happens? The depth decreases, cost increases, and time taken for the result also increases. So what are genetic variants? Basically, these are the changes which are found in compared to reference sequence. These can be either de novo or they can be inherited from the parents, one parent or from both parents. And in this slide, I am showing that what is the size of these defects. Like in single nucleotide point mutation, the size is 1 base pair. In small insertion and deletion, the size is around 100 base pairs, 10 to 100 base pairs. As we move further, like in copy number variation, the size is 1 kb to 1 around 100 kb. In large chromosomal aberrations, the size could be up to 100 MB. How we interpret these variations? Basically, variant interpretation refers to assessment of pathogenicity, which we derive from individual variants to disease phenotype. Like in Sanger sequencing, it is easy because we sequence only single gene. In NGS new generation sequencing, multiple genes are sequenced, so it is more complex and challenging task. So when we find the gene, we have to classify it further, whether it is of it is fitting into phenotype or not, it is diseasing causing or not, or whether it is of uncertain significance. So after we have find the variant, we further classified it into whether it is pathogenic, likely pathogenic, variant of unknown significance, likely benign or benign. Then we further classify this in this classification is basically based on ACMG classification. When a variant is classified pathogenic, means it is affecting the function of the gene. There is more than 99% chances that is it is affecting the function of the gene. And when it is benign, means there are very low probability that very high probability that it does not affect the function of the gene. Then for benign and pathogenic, evidence are taken. Like in benign, there is evidence is strong or supporting. In pathogenic, whether evidence is supporting, moderate, strong, or very strong. Basically, these databases are useful to identify the evidence for variant interpretation. They are no longer employed as independent criteria. There are 16 pathogenic criteria and 12 benign criteria. Then long read sequencing. Basically, this is a third generation platform and it delivers single molecular precision over vast distance. And what is the mechanism behind this? Basically, platform like Pacific Biosciences, SMART enables, they sequence the single molecule without amplification. In resolution, it provides high accurate continuous read average of around 10 kb or longer, bypassing the alignment issue of short read fragment. And its ability is suited for its de novo assembly of novel genomes, deciphering highly repetitive genetic region and mapping methylated bases directly. This next diagram is showing what is the difference between the NGS and long read sequences. Basically, in this short read, this showing that white lines are missing. Or basically, in long read, these sequence gaps are also red. So in case of short read, we might miss sequences leading to gap in genome coverage and limit variant detection. And in long read, basically it map uniquely and span largely variant, providing comprehensive variant detection. Then multiomics. As we all know that no gene act in isolation. By seeing the DNA sequence, we can predict whether this protein will be formed or not formed. But by knowing the function of messenger RNA, knowing the proteomics or metabolites, we can diagnose we can identify disease to a holistic and system level approach. And in multiomics, basically we study genomics, like we entirely map the DNA variants. We study the proteomics, the full complement of translated proteins. In metabolomics, we study the metabolites and their cellular alteration. In transcriptomics, we analyze the RNA expressing pattern. Basically, multiomics include all these processing, not only the genomic sequencing. Multiomics generate data set which are beyond the capacity of traditional human interpretations because it is taking whole layers into account. Then single cell omics. In single cell omics also, we can study the single cell genome, transcriptome, proteome, and on this basis, we can identify cell type, we can reconstruct lineage reconstruction and regulatory networks. From single cell omics, we can study the transcriptome of single cell, chromatin stability, histone modification, DNA methylation, etc. In epigenomics, basically in genomics, we are studying the DNA sequence. But in epigenomics, basically, we are studying the molecular tags which are associated with DNA, like methylation, histone protein arrangement around which the DNA is folded. So this is studied with the help of chromatin immunoprecipitation. And these are helpful in to know how viral protein interact with the human genome. They help in revealing the regulatory mechanism, DNA repair process, etc. Then pharmacogenomics. In pharmacogenomics, basically, we are studying the genetic profiling into precision therapeutic. Like we are giving standard dose for the patient who are having the optimal metabolism rate that will achieve the maximum therapeutic benefit. Or for example, if patient is having slow metabolism, so we have to reduce the dose of the drug. Otherwise, it will lead to the toxic accumulation of the drug. By studying the genetic makeup, we can find out which drug have severe adverse reaction with genetic makeup of the patient. We can find alternate therapeutic pathway also. So ultimate goal for pharmacogenomics is tailored specific drug and exact doses to the patient, unique biochemical state. Then AI in genomics. Basically, AI provide massive data sets to build proactive healthcare system. It can predict massive population level screening models. It can prevent diseases, like we can know the diseases before the disease onset. So it helps in modifying lifestyle. We can intervene long before the clinical disease begins. And cure, it helps in accelerating the discovery and precise deployment of targeted gene therapy and molecular treatments. Then newborn screening. In newborn screening, on right blood spot is collected with the heel prick method. We take sample from the heel of the newborn. Then it is a laboratory process, analyze, and reporting is done. Basically, it is a population screening tool for babies before the symptom appear. So what is newborn screening? Basically, it is a public health program for early identification of serious condition newborn. And this detect disorders even before they appear. By this, we can do early treatment and prevention of complications. The objective of newborn screening is to reduce the infant mortality and morbidity, prevent intellectual disability, physical disability, and it will improve also long-term health outcome and help in providing early intervention and counseling. What is the importance of early detection? Basically, it will prevent the irreversible damage. We can do timely treatment, improve survival rate, reduces healthcare cost, and advantage include early diagnosis, cost-effective public health strategy. It reduces disability burden, improves the quality of life. Limitation is false positive, false negative, limited panels in sub-region, and require follow-up. And in some cases of false positive cases, it also produces parental anxiety. Basically, this comparison between the standard newborn screening and the expanded. In standard newborn screening, earlier it was for 3 diseases. Then it was for increased to 6 diseases. In expanded disease, it covers around 30 to 50 diseases. And in standard newborn screening, we are using basically ELISA test. And in expanded newborn screening, we are using the TMS technique, tandem mass spectroscopy. The cost of basic newborn screening was low. It was increased in expanded, but the advantage is that it is including higher number of the disease. So we can detect wider range of severe conditions at early phases. And it is cost wise, it is higher as compared to basic newborn screening, but is more effective as compared to basic newborn screening. Now, what are the benefits of genetic diagnosis beyond treatment? By doing the genetic diagnosis, basically, we are able to find the diagnosis. We are able to confirm the disease of the patient. So patient is saved from additional testing and avoid invasive procedure. We can provide the information to the patient about the prognosis and natural history of the disease, anticipation of the medical needs, and what are other reproductive options. Patient can join target support groups, and patient can have access to clinical trials or some observational studies. We can inform family about recurrence risks and reproductive and other life planning options. And patient also know the reason for his disease. He get relief from guilt and misconceptions. Now, what are recent therapeutic advances? Recent therapeutic advances include enzyme replacement therapy, substrate reduction therapy, gene therapy, mRNA-based therapies and genomic editing, nutrition and metabolic modulation, and protein precision medicine approaches. And by these advances in the diagnosis and treatment, basically, we are shifting from the phenotype-driven to genotype-first diagnostic, and time to diagnosis has markedly reduced. There is increasing number of modifying therapy, and it helps in increasing survival and improving the neurodevelopmental outcome. Basically, enzyme replacement therapy is used for lysosomal storage disorders like Gaucher's disease, Pompe's disease, MPS, and it is also used in other conditions also like ADA deficit, severe combined immunodeficiency. Till now, 14 approved ERTs we have, and there are many additional therapies going on. The basic mechanism of enzyme replacement therapy is it replaces the deficit lysosomal enzyme, and it targets lysosome by mannose-6-phosphate receptor enhancement. So it helps to reduce the substrate accumulation. What are limitations of enzyme replacement therapy? As we know that enzyme replacement therapy is not able to cross the blood-brain barrier. So the CNS effect, it have no improvement in CNS manifestation. And it also has poor penetration to skeletal system. So there will be limited impact on the disease in which there is effect on the central nervous system and skeletal system. And it is a lifelong therapy, and it is used for lysosomal storage, also used to stabilize the patient before hematopoietic stem cell transplantation or when hematopoietic stem cell transplantation is contraindicated. Basically, this slide is telling about the disorders in which enzyme replacement therapy is given. But in our country, the enzyme replacement therapy is given for the drugs for the diseases which, for the ERT which are approved by DCGI. So in our country, it is given for Gaucher's disease, and it is available in brand name of imoglucerase, velaglucerase, and teleglucerase. And it is given bi-weekly. It is given every 15 days, IV infusion over 2 hours. And it is also given in Fabry disease, MPS 1, 2, and Pompe's disease. And in other countries, it is also given for NCL, phenylketonuria, adenosine deaminase deficiency, hypophosphatemia, alpha mannosidosis, MPS type 7 and 6. Then pharmacological therapies. So bisphosphonates are one of the emerging pharmacological therapies. It helps in bone strengthening therapy. Basically, it inhibits the osteoclastic bone resorption and increases bone mineral density. These are indicated in osteogenesis imperfecta, and 2 drugs are available, pamidronate and zoledronate. Both are given IV, and Jolie donated given once a 6 months by IV route. So it is given once a 6 months, so it is more preferred. Then statins, these are used in hypercholesterolemia and they inhibit HMG-CoA reductase. So they reduce the endogenous cholesterol synthesis and also upregulate LDL receptor. So there will be reduced plasma LDL. As compared to statins, there is other therapy also, which is advanced lipid lowering therapy, that is PCSK9. Basically, it targets PCSK9 and prevent LDL receptor degradation. So it will reduce LDL around 50 to 60% more than statins. Example are evolocumab and alirocumab. And indication include familial hypercholesterolemia, atherosclerotic cardiovascular diseases. And then we have everolimus. Basically, this therapy is for tuberous sclerosis complex, and it inhibits the mTOR pathway. So it will reduce cellular proliferation, decreases angiogenesis, and it promotes tumor cell apoptosis. Then in hematological therapy, we have hydroxyurea that is used in sickle cell disease and thalassemia intermedia. Basically, it used in these disorders by increasing fetal hemoglobin, and it reduces painful crisis in sickle cell anemia. Then we can also give prenatal treatment for some of the genetic disorders, like in congenital adrenal hyperplasia, we can give dexamethasone to the mother. It will suppress the fetal pituitary adrenal axis and reduces excess androgen production. By doing all this, it will prevent the virilization of the external genitalia of the female fetus. Then small molecule chaperone therapy, basically chaperone, basically protein misfolding caused by genetic mutation. And this misfolded proteins are degraded in endoplasmic reticulum, and pharmacological chaperones help to restore the protein folding. So basically these small molecule chaperones bind to the mutant protein. They stabilize the correct folding and improve enzyme trafficking to correct cellular location. They will increase the functional enzyme activity. So mainly they are useful in lysosomal storage disorders. They help to rescue partially functional proteins. They are generally safe and orally administered, but limitation is that they are mutation specific response, and they will increase the functional enzyme activity. The example of this is megalstate. It is used in, it is not megalostat, it is megalstate. It is used in Fabry disease. It acts on alpha galactosidase enzyme. It will stabilize the enzyme, improve trafficking. By improving trafficking, it will increase the activity. And the other example are protein folding, improve chloride channel function. So for this, there are characters like characters for protein folding and trafficking, that is lumacaftor, tezacaftor, alexacaftor. Basically, these will help the CFTR protein to reach cell membrane. And there are potentiator for channel function, that is evacaftor. It will increase the chloride channel opening and probability. By all these effects, in cystic fibrosis, there will be restoration of the chloride and water transport across epithelial cell, and it will help to improve the lung and other organ functions. Next slide. And in basically in substrate reduction therapy, there is reduced synthesis of the substrate reduction therapy helped by reducing the synthesis of accumulated toxic metabolite. Basically, this is used when enzyme deficiency lead to buildup of metabolites, and it acts by inhibiting the substrate or precursor formation. It allows the residual enzyme to work efficiently. It may cross blood barrier. ERT is not able to cross the blood-brain barrier. And one advantage of substrate reduction therapy is that it may be administered orally and it has lower immunogenicity. Next slide. Next slide. So in substrate reduction therapy in Gaucher's disease, we use miglustat. It is used in type 1 Gaucher's disease. It inhibits the enzyme glucosylceramide synthase. And one of the major side effects of miglustat is gastrointestinal intolerance for some patients. And iglustat, it is also therapy for adults with Gaucher's type 1. And it is effective in individuals who are CYP2D6 genotype dependent. Other example of this is Genistin of substrate reduction therapy. Next slide. Then in small molecular therapy, other is stop codon read-through enhancer and splicing modifier. Basically, they are used to treat disorder which are caused by premature stop codons or abnormal splicing. And they restore the full functional protein production. And their mechanism of action is they enhance the stop codon read-through or they modify the mRNA splicing pattern. So there will be increased production of the protein. And one of the very important drug which work on this mechanism is risdiplam, which is effective in spinal muscular atrophy. And it acts on SMN2 gene. It prevents exon 7 skipping. And with the help of this drug, there is full length SMN protein production. And one advantage of risdiplam is it is orally available and it is given orally once daily. Then other drug is etalurane. It is basically effective in Duchenne muscular dystrophy. And the mechanism of action is allow ribosome to bypass premature stop codon. So it will produce partially or fully functional dystrophin. So it leads to milder Becker type phenotype. Then in RNA modification therapies, we have RNA interference therapy. It targets mRNA, prevent protein production. And it is more potent as compared to antisense oligonucleotide. In RNA modification, this RNA interference therapy is available and antisense oligonucleotide therapy is available. Next slide. In antisense oligonucleotide, basically these are single-stranded DNA or RNA. These are constitute of around 80 to 30 bases. And their mechanism is that they bind complementary mRNA. So they prevent the translation into protein and they may induce the degradation of mRNA. Next slide. Advantage of ASO is they are highly specific. They have targeted gene suppression, effective in several genetic disorders. Challenges is they are mutation specific. So for each mutation, we need a unique ASO. There is high cost of development and limited availability for rare mutation. So nusinersen is example of ASO, which we are using in spinal muscular atrophy. Basically, it binds to the embryonic ISS N1, embryonic splicing silencer N1 site on the SM2 genes. So it will displace the splicing factor that normally suppresses splicing at this location. So it will lead to the retention of SMN2 exon. So we get full length SMN2, then that can be translated into functional SMN protein. And it is FDA and nusinersen is FDA and EMA approved, and it is effective. It is tried for SMA type 1, 2, 3 for ages 0 to 12 years, and it is administered intrathecal. Then RNA interference therapy, basically these act at mRNA level. These are more potent as compared to ASO. They are used for target specific gene knockdown. And mechanism of this, they activate the RNA induced splicing complex, lead to cleavage and degradation of mRNA. Basically, their result is gene silencing or knockdown. And they are more effective as compared to SA. They are highly specific targeting of GNA. They are ideal for selective genetic gene knockdown. And Examples of these are patisiran, which is used in hereditary transthyretin amyloidosis, lumasiran, which is used in primary hyperoxaluria type 1. Then what are the transplant therapies available in genetic disorders? First is hematopoietic stem cell transplantation. Basically, in hematopoietic stem transplantation, we are replacing the defective bone marrow with healthy stem cells. And it is used for multiple genetic and hematological disorders. And it is curative in selected conditions. In hematological disorders, it is indicated in beta thalassemia and in inherited bone marrow failures. In immunodeficiencies, it is indicated in severe combined immunodeficiency, Wiskott-Eddy syndrome, in CGD, leukocyte adhesion defect, in familial hemophagocytic syndrome. And liver transplantation in metabolic disorders, basically liver transplant are done in cases of urea cycle disorder, tyrosinemia, Wilson's, and maple syrup urine disease. And now the gene therapy. Basically, this is the therapeutic approach to correct the defective gene. We can do either by gene replacement or gene editing. And the first trial was began in 1990. The first FDA approved gene therapy was Luxturna, and it will target the underlying cause of genetic disorder. There are several gene editing techniques like gene finger nuclease, TALEN, CRISPR-Cas9, and these are used in sickle cell disease and Leber congenital amaurosis. There are two methods of mechanism of gene transfer. We can do by ex vivo or in vivo. In vivo, we directly transfer the gene delivery into the patient. In ex vivo, first we remove the cell, then modify, then reintroduce. This diagram is showing the how we do in vivo and ex vivo. Like in vivo, stimulus for SCID is given in vivo. In ex vivo, first patient cells are taken, then clone gene is transferred, then cells are cultured, then selected cells are returned to patients. Recent approved therapies is giant teglo. It is used in beta thalassemia, and it is given by ex vivo route using lentiviral vector. Second is Roctavian. It is used for treatment of hemophilia A, and it requires only single dose. Advantage of gene therapy is basically it is targeting the root cause of the disease, and it is long-term or permanent cure. It reduces need for lifelong treatment. Challenges are there in gene therapy like safety and efficacy concern, immune response to host to vector, high cost, need for long-term studies, and interaction with host cells. There are two types of vectors for gene therapy, viral vectors and non-viral gene delivery system. In viral vectors, mostly viral include retrovirus, lentivirus, adenovirus, adeno-associated virus. In this non-viral delivery system, there is liposome-mediated DNA transfer or synthetic delivery system. This slide is showing comparison between viral and non-viral vectors. Basically, viral vectors have high efficiency, moderate safety, and there is some possibility of adverse response of immune response, and DNA capacity limited. Whereas non-viral vectors have low efficiency, they are highly safe, immunogenic response is low, and their DNA capacity is large. This slide is showing the gene therapy for various diseases like Luxturna is used for retinal dystrophy caused by biallelic loss of function, RP65 mutation, and it is given by AAV2 virus. The normal copy of the gene is introduced. And Zolgensma, which is used for SMA patient less than 2 years of age. Now it is also in trials for higher age group. It is given with the help of vector AAV9 with the intravenous route. And then Stimulus, it is for ADS SID. It is given by retroviral vector. Then giant teglo is for beta thalassemia. Roctavian is for severe hemophilia A. Then this Zolgensma is for SMA. It is gene therapy for SMA. And why treatment of SMA is possible by gene therapy? Because SMA is caused by defect in the single gene. And this gene therapy also cross the blood-brain barrier. It is given by intravenous route. So it is introduced with the help of vector, which is non-pathogenic, non-replicating, non-integrating AAV9 capsid. So it is the functional copy of the human SMN1 gene is delivered to the individual motor neuron cells to replace the missing or defective SMN1 gene. So with the help of this gene, the cell is able to initiate the expression of SMN protein once released into the nucleus of the host cells. As we all know, SMA is a strong candidate for successful gene therapy because it's caused by defect in single gene. And it is given by IV route over 60 minutes. It is given in children less than 24 months of age. And it is given by intravenous route. Intrathecal routes are also in trial phase, and higher age group also is in trial phase. And this slide is demonstrating the comparison between the different therapies which we are using for rare disorders like dietary therapy. We are using for small molecular disorders like phenylketonuria or tyrosinemia. Advantage of this is it is easily available, cheaper, but disadvantage is that it is lifelong therapy and does not correct the basic gene defect. And in enzyme replacement therapy, as also we know that these are for lysosomal storage disorders. Advantage is that they have fewer side effects, but disadvantage is that patient require the lifelong intravenous therapy. They does not cross the blood-brain barrier, and in some patients they have immune response. In substrate reduction therapy is tried in Gaucher's type 1 and MPS type 3. Advantage that it is oral therapy. It crosses the blood-brain barrier, but it is not widely available. Then chaperone therapy is tried in Fabry disease and cystic fibrosis. Advantage is they are only therapy. Main limitation is that it is lifelong intervention and does not cure the underlying disorder. Then hematopoietic stem cell transplantation, it is tried in severe combined immunodeficiency, LSDs, X-linked adrenoleukodystrophy. So basically, main advantage is they are effective in neuronopathic phenotype in which ERT is not effective. And basically, these are correcting for some disorder. These are for some patient. This is basically cure for the disease. But main disadvantage that we have very difficult to identify HLA match individual. And liver transplant is also tried in urea cycle defect, tyrosinemia, Wilson's disease. So basically, it provides relief and better lifestyle quality with no dietary restriction, but we need matched donor, and there is risk of immune response. And in polycystic kidney disease, primary hyperoxaluria kidney transplant is tried. RNA-based therapies are tried in spinal muscular atrophy, familial hypercholesteremia. Gene therapy is tried in spinal muscular atrophy, beta thalassemia, severe combined immunodeficiency, retinal dystrophy. Prenatal therapy is given in case of congenital adrenal hyperplasia, heart block, and hormonal therapies which we are giving for Hunter syndrome, Prader-Willi, and Noonan syndrome. Basically, these are a management approach, not curative. Thank you.
Thank you, Gayatri. That was a wonderful, detailed information, and ORDI truly appreciates your gesture. Thank you so much.
Thank you. Thank you, ma'am.
One thing I want to ask, like, what is the status of gene therapy in India? Like for SMA, it's being done in Bangalore. It's being done, and what about other causes like ocular Leber's?
Basically, at our center, we have given gene therapy for SMA only. We have given gene therapy for SMA only to the 4 patients. And now gene therapy is also approved for Hunter syndrome also. Gene therapy
In our
basically
country,
like this for Hunter syndrome, it is approved, and It is also given for this retinal disorder in RP65 mutations, in hemophilia.
Is it being done in our country for RP
Uh,
65?
it is approved. It is approved in our country.
We find it so difficult to arrange for enzyme replacement therapy because of the high
Ma'am,
cost, and we only hope that gene therapy becomes available.
but ma'am, due to the policy of national policy for rare disease, some patients of this Gaucher's disease, Pompe disease, and MPS are able to avail the enzyme replacement therapy under
Correct.
national policy for rare disease. Otherwise, it is very tough because cost is very high.
Yeah, it's very high. We only hope that gene therapy comes soon and for many more diseases so that we can tackle the problem at the root. One second. I think there is a question. I'll just check. Mr. Vikas Bhatia wants to know, is SMS Medical College currently conducting universal newborn screening?
Basically, we are in process to start shortly newborn screening. Earlier, we are doing newborn screening, but now there is some deficiency of kits for NBS. So government is slowly planning to start the newborn screening. Within few months, it will be started.
Okay. Are treatments such as modified diets and specific drugs available at your facility?
Ma'am, for the diseases which are covered under national policy for rare disease, in our institute there is Yojana, Bal Sambal Yojana for the rare disease patient. For the 56 diseases which are covered under NPRD, like in tyrosinemia, patient can avail nitisinone and modified diet under the this Bal Sambal Yojana scheme.
And what
We
about
are
prenatal? Yes, ma'am.
we are giving treatment for the only for the disease. We are knowing the treatment, but patient is basically cost of treatment is very high, so patient is able to afford only through the Bal Sambal Yojana.
What about prenatal diagnosis for high risk families, ma'am? Suppose a patient is diagnosed with a condition and they want to get pregnant again. And what about the prenatal diagnosis for high risk families?
Basically, for example, some patient is diagnosed with some genetic disorder. Basically, we do the first counseling of the patient, or we do the screening of the both parents for the disorders, for the genetic disorders, for parents. Mother and father both do. We have fetal clinic at Mahila Chikitsalaya in Jaipur. And there, they're by fetal medicine expert. The second level ultrasound is done, and the procedure like amniocentesis and chorionic villus sampling are performed at there in SMS Medical College.
Is the Mukhyamantri Ayushman Bal Sambal Yojana currently active and providing financial assistance to the families, ma'am?
Yes, ma'am. Patients are getting 5,000 rupees per month and also getting treatment. We are giving, patient are receiving this imiglucerase for Gaucher's disease, and they're also receiving an ERT for Hunter disease. For Hunter disease, they are coming every week, and for this Gaucher's disease, they are coming every 15 days. And they're also receiving oral risdiplam for SMA.
What are the new available therapies for conditions like phenylketonuria and Gaucher's disease, other than enzyme replacement?
For Gaucher's disease, madam, we have this oral substrate reduction therapy like miglustat. But these are tried in older age group children's. And one of the important side effect of this is GI intolerance. Many patients report this side effect. And the cost of therapy is also very high.
Okay. Okay, ma'am. Thank you so much for a wonderful session. ORDI really appreciates. Thank you so much.